Yeah, thank you once again for the opportunity. The previous talk by Dr. Horst Sievert was on Ceraflex PFO device. The Ceraflex was not available in our country till now, and we are doing the first case in India today. I have with me Dr. Anand Kumar, who is my colleague, and Sister Shweta, who is assisting me. Dr. Pramod is doing the echocardiogram, and Prabhu and Surya are the radiographers. So can I request Dr. Alka, who is one of my junior colleague, to present the case details?
Good evening. I am presenting the case details of the current live case. It's an
We can't
18-year-old
hear
male
you.
who has
We
been
can't hear her
asymptomatic.
very well.
1 month back, he had a URI, and
Okay,
the
that's
doctor
good.
detected him to have a murmur. And when he was evaluated, he was found to have an ASD. He is a well-built, well-nourished kid with 76 kg. He on examination, he has mild cardiomegaly, normal S1, S2 is wide fixed split, and there is a 2/6 ejection systolic murmur in the left upper sternal border. This is his X-ray, which is showing mild cardiomegaly, hyperinflation, and mild plethora. His ECG is showing prolonged PR interval and normal QRS axis and normal ventricular forces. Coming to his echocardiogram, his thoracic echo showed a 22 to 24 millimeter ASD with a mild pH with RBSP of 40. This is his transesophageal echo showing the ASD, 0-degree view. Now, this is a biplane view of the same defect. And in this 90-degree bicaval view, we can see the defect measures around 24 millimeter. And this is the 3D view of the defect. It measures around 23 into 19 millimeter. And the margins are all adequate. And plan is to close with a LifeTech Ceraflex device. Thank you.
So, Shak, you would have heard the presentation by Dr. Alka. This Ceraflex device was, as I told you earlier, was not available in our country. I would like to show the device. Can you focus on the device? So basically, this is a LifeTech device. The term Cera refers to a nitinol alloy being coated with titanium nitride. The titanium nitride is supposed to reduce the leaching of the nickel into the circulation. Contrary to the regular LifeTech devices that we have in our country till now, there is no central hub. So we can appreciate that there is no central hub. The device make is more or less the same. However, the proximal end is not held by a screw system. Can you zoom in here?
We can see it.
Okay. So we can appreciate that it is held basically by a suture. This allows the device to be rotated almost 360 degrees. Thereby, there is no tension of the cable over the device after the device reaches its stable position. So obviously, in a patient in whom the hole is pretty large, for example, that needs say a 36 millimeter or a 37 millimeter, which is going to need very large devices like 40 or 42 Cera, this system is not going to work so well. So the largest Cera device is 32 millimeters. It has got a left atrial disc and a right atrial disc, and it comes with a delivery system. So this is the delivery system. I am now flushing the delivery system. The way to load this will be, you make the device sort of coaxial, slowly pull the hub inside, and once it enters, get the device into the sleeve. You elongate the device in order to get it inside the sheath fully. I'm going to flush this.
But you don't do this underwater, is it?
I will do it underwater, Bharat, but I wanted to show to you.
Okay. Okay.
I will repeat it underwater. You will not be able to see underwater, Bharat. The way you see
No,
that
no,
you will.
I get your point. I'm sorry. I get
Yeah.
you.
So now I will show from this end. Now actually I am pushing the device out. The part of the procedure, what is happening within the utensil, you have to believe me. So I have loaded fully. This device has got a delivery apparatus here. It has got a brown colored knob on one side and a blue color knob on one side. While we are deploying the device, we will just use only the cable to push and get into the stable position. Once we are reaching the position to release it, I have to press this brown button tightly and then move this blue button posteriorly like this. I will try to show that during the deployment. And when we do that, the suture comes out and the device is separated out. So now let me take it. Dr. Alka showed that it is a 24 millimeter secondum ASD with deficient retroaortic margin. And as is our policy, we don't do balloon sizing. We normally try to upsize if the margins are good, about 4 millimeters. So this is a 28 millimeter Ceraflex device. Show the packet.
Just remind us what the defect measurements were. I've forgotten.
24, Shaq. 24.
And,
so we are going +4.
Shiva, you would have used the same size device had it not been Ceraflex, but only LifeTech. Do I understand you correctly?
Yeah, I would have used, if this patient comes to me for a regular device, I will use a 28 millimeter as regular Cera device or a regular Amplazer or any other device.
Okay.
+4.
Okay.
Because the margins were stiff. He's an adult, and I would go for +4. I forgot to tell you, the RA mean pressure and LA mean pressure were 6 millimeters of mercury. The RV pressure was 45 millimeters of mercury with an end diastolic of 10. PA pressure is 45/15 with a mean of 30. The QP by QS was around 1.8:1. The patient is having a small dose of dexmedetomidine running right now to keep him quieter. And now I'm going into the 14 French sheath, which is recommended for the larger Cera devices. So now I'm advancing the cable. I've got a 14 French sheath already parked in the show fluoro live. Fluoro live, not my photo. Show full screen fluoro. There is nothing in hemodynamics to show. So here I will go on Cine so that you will be able to see the pictures better. So I have deployed the left atrial disc. Now, since this device does not have a good hub on the left atrial side, I'm just pushing against the left atrium in order to flatten the device. Now, at this point, I will ask Pramod Sagar, who is my colleague, to show me one apical 4-chamber view. Make apical 4-chamber bigger. So now on echocardiographic guidance, I'm going to slowly withdraw my device up to the atrial septum. So I'm touching the atrial septum now. At this point, I'm going to request Dr. Pramod to remove his hands out. Eye scan, Pramod. I think it's too bright there. Eye scan. Yeah, that's good. So maybe parasternal short axis also once. Just sweep superiorly till the aortic root is seen. It looks like I may be slipping out the aorta. I'm just giving a gentle push on that side. Okay, Pramod, I'll do one thing. I'll give a clockwise torque and then see whether I can rotate this device away from the aorta. Try to see one parasternal short axis now. Make echo bigger. Shaq, what do you say? Probably I should have taken a plus 630 device, or this 28 is because in a normal device, sometimes I use pulmonary vein deployment.
Yeah,
Here, this device does not allow too much of manipulations.
you read my mind. Because it's an adult patient and the rims are stiffish, but
Okay,
Poppy,
Pramod,
I
take
would
your
have
hands
gone
out.
for 30, but also I would have gone with that aortic rim deficiency. I would have probably gone for a right upper pulmonary vein deployment to start with. You could try that now as well, of course.
Show the short axis view. It looks better.
Yeah, much better.
Yeah. Okay, hands out. So the advantage of this device is that there is no tension on this cable. It gets profiled very well. Now, can you check, Pramod, the position? It looks fluoroscopically good to me.
Yeah. Bharat, any comments?
No, I think that right upper pulmonary vein was a way to go probably, and looks good.
With deficient aortic rims, I pretty much hardly ever deploy the devices conventionally. I go for the right upper pulmonary vein to start with.
I agree, Shaq. Yeah. This device, actually, we have not had an opportunity to use till today. This is the first device that we are taking up. But I thought since Dr. Hosewert introduced this device, it will be nice to show live to the audience. Subxifoid also tried out, Pramod. We, since the previous patient was moved to the theater, we had less of time to organize a proper transesophageal echocardiogram, but we will assure you that we will try to get as good images on thoracic as possible. Pramod, if it is not coming up, it's okay. I think apical 4-chamber.
Subject, Shiva, how is the patient.
The surgeon is just opening the sternum. I will join him in another few minutes after I complete this live case.
Transfer was stable and everything.
Patient is stable. Yeah. Rhythm was stable. The blood pressure was around 110 to 120 systolic, no inotropes, no ectopics at all. We pulled out that long 24 French sheath and changed it into a short 24 French sheath so that the surgeon can advance a 23 perfusion cannula through that femoral vein. We left the wire as such. The left femoral vein and artery we converted into some triple lumen for the inotrope infusions and other, the anesthesia purposes. Can I once see the echo myself?
Okay. You can fill us in more about that patient tomorrow.
Tomorrow, I'll show you.
Let's
Pramod, eye scan. Okay, now I want a zoom on this. Yeah. So the mitral margin, can you put color on that? It looks okay here. So now I'll go for parasternal short axis. Go on zoom on that. Color. I'm going to go on sub-Ziphioid, just adjust the depth. Zoom on that. Eye scan. It's a ghost-like image from the sub-Ziphioid. I think probably I have to be happy with this apical 4-chamber view.
Yeah.
And this parasternal short axis view.
Yeah.
Also the fluoroscopy.
So now I will show the, yeah, and Dr. Bharat, any questions?
I just said, and also the fluoroscopic view.
Yeah, sure. Anand, show one fluoroscopic view, a short cine. Enough.
One of the things you can do to show the flexibility of the system is try and show the LAO with a bit of cranial to show the two discs.
Sure. I will do some subtle movement of the cable so that people appreciate. LAO.
See the angle of the cable in relation to the device, and in a normal course of events you would have a lot of
more LAO.
on
Or
the
a small contrast. Full LAO, little bit more LAO, make the device on its profile, fully on its profile. Correct. Go more cranial. Okay, fine. Can you give me some contrast? I'll just fill the right atrium so that we get the orientation of the right atrium, and then allow a long levo phase to get the left atrium filled. Sorry.
Oh,
There was a
few bubbles.
yeah, not few on the
I was being polite.
yeah.
At least they're on the right side of the heart.
Yeah. Non-invasive blood pressure is 108/62. Okay, now come to AP view. So now I go to the device release. So here I am catching here. You show it bigger. Show here. Come closer. So the undersurface is the brown color. So this brown color I am now pressing.
Shiva, it may be worth splitting the screen into two equals so that we can see your hands.
Okay, screen into two equal screen size. Yeah. Okay, now 50% screen, this one, and 50% fluoroscopy. Correct.
That's better.
So now with my index finger, I have pressed the brown button. And now I am going to move the blue button.
Okay, good. No movement at all, other
Yeah.
than beating heart.
The only thing is the few bubbles of air that I injected are trapped in the anterior wall of the right atrium and anterior wall of the right ventricle. But the patient is remaining stable. As you mentioned, it is on the right side. I should have flushed the sheath nicely before injecting, but sorry about it.
Try aspirating and see.
Make the actually we don't have an arterial pressure. The pressure is stable. Saturation is 99%.
But yeah, you could, with your sheath, you could, don't want you to do it too much, but you could try aspirating really hard and see if you suck any bubbles out.
I'm trying for that, but
not too close to the device.
yeah, it is. It's trapped within the region of the atrial appendage tract. You are able to see that it's. I'll show you a fluoro.
Yeah, apex as well. Yeah.
Yeah, apex as well. So, so we wanted to demonstrate. I mean, the patient is remaining stable. The heart rate, the saturation, the blood pressure, all are remaining stable. So, any questions about this particular device? If there are questions, Dr. Shakil Qureshi will be answering them, because this is the first device that I am using. I don't have any experience about this device as such. Shak, if I ask you a question, would you prefer this device over a conventional Cera device on all your routine cases?
Well, the main problem at the moment is the upper limit of the size, isn't it?
Yeah.
So for this size or less than 32, yes, I would prefer this, because in some of the challenging anatomies, the suture has an advantage. Occasionally you have to be, well, not occasionally, when you're releasing the suture, you still have to be careful in pulling it, because it doesn't necessarily completely release straight away. So you need to take a bit of time, but it's a good device.
Yeah, true. Actually, even though this device has been in use in Europe, South America, the Southeast Asia, we did not get an opportunity to use this product because the other device, Cera, was freely available across the country. However, just I think, I mean, 2 or 3 days before, these devices were brought into India and they were given to me yesterday.
Okay.
So this is now the echocardiogram. I thank the organizers of this conference for giving us this opportunity, and I thank all my colleagues, the nurses, all my colleagues, the hospital administration, for having supported many of these live transmissions. So if you hold on, Shiva, Mario is connected to us and he wants to say something. Mario.
Hello, Siva. I enjoyed a lot your procedures. Congratulations. Forget about the bubbles in the right heart. I would say that I have some experience in using this device for both PFOs and ASDs, and I must say I'm very, very happy. Particularly, is very soft, very flexible, very effective. And I would say the mechanism of attachment, which is the suture, has the advantage as compared to, let's say, the Trevisio cable for the ABO devices, in the sense that the final position is completely identical as compared to when the device is still attached. So that's an advantage, in my opinion. And in fact, particularly for ASD, for large ASDs, I don't want to have a big jump of the device when I detach it. And this is completely avoided by this device. Yeah.
Okay, thank you, Mario.
I agree, Mario. Actually, I'm just showing the release. I'm showing the release. It's true that there is no movement of the device at all.
Yeah,
When the cable comes out, we are hardly seeing any movement of the device.
Yeah, that's right.
okay. Shiva, well done to you and the whole team. Excellent demonstration there.
Thank you, Shiva. Thank you for
Thank
the
you.
nice case and the nice demonstration. Thank you.
Thank you very much.